But I think what's interesting too is going into the Trump administration, Trump doesn't drink.
I was just thinking
and
that.
His older brother would always tell him not to drink. And his older brother died from alcoholism, from a heart attack in his 40s. RFK is a former heroin addict. He goes to AA meetings, and his younger brother died at 28 years old from a drug overdose.
Yeah.
I would believe that coming from the top,
this will carry on.
This will carry some weight, I think.
This is Generation Health. We bring you the latest news, cutting-edge research, and time-tested best practices helping you live a longer, healthier life. Across from me, Joey DiMatteo, PharmD, board-certified clinical nutritionist. How are you, my friend?
Very good. Thank you.
Excellent. And to my right, Dante DiMatteo, PharmD. How are you?
Doing well. Thanks, Tyler.
Excellent. And riding microphone number 4, Josiah Schweinberg.
All right.
Locked in.
Engineering so. Over there.
Just checking everything out.
Love it.
Engineering.
Love it. My name is Tyler Andrews. I'll be your host. This week we got a lot going on. I don't have a fun question. Everybody doing well? You guys were talking about sports. That's always a conversation I'm not a part of.
Yeah, that's a long one right now in Pittsburgh area.
Yeah.
Tough.
Tough times.
Well, good luck. Good luck to all of you, and go sports ball. No, let's dig into it. We've got a great article. This is fun. This is going to lead to some interesting conversation. This is from CNN Health. U.S. Surgeon General sounds alarm about link between alcohol and cancer. Just read a little bit of this here. U.S. Surgeon General Dr. Vivek Murthy issued an advisory Friday warning about Americans with that alcohol consumption can increase their cancer risk, and called for an updated health warning label on alcoholic beverages. Surgeon General's advisories are strongly stated warnings meant to deliver clear messages about health risks. Advisories are uncommon and reserved for issues that need immediate awareness and action. They often become turning points in the nation's health habits. A 1964 Surgeon General's warning on smoking, for example, started to change the perception that cigarettes were benign. The new advisory may help do the same for drinking, which was once thought to be associated with some health benefits. The new report aims to dispel any notion that alcohol is harmless. Now, obviously, this is the last administration, the Biden administration, tail end of that Dr. Murthy is doing this. But guys, do we really think that an alcohol warning label is going to make people stop drinking?
I was skeptical about that question, myself.
Mm-hmm.
I mean, after digging in a little bit, I would say that at the very least has the potential to raise awareness and do a little more education on a large scale.
This is, so one of the first things they said in there, alcohol thought to be benign, or at least in some instances beneficial, right? You're supposed to drink a little bit of red wine. It's good for blood health, things like that. Is that all nonsense? Have we completely done away with that idea now?
I think that's still pretty mixed. I don't know what you saw, but in terms of those studies themselves and evaluation of those, it's mixed at best.
Okay.
I always refer to it as a study, but technically it's a report. It's the Surgeon General's advisory. Specifically, I think to avoid a lot of kind of the noise that can be around this is they stick to cancer specifically.
Okay.
And they stated in here, it's the third leading preventable cause of cancer.
Behind obesity and smoking?
Tobacco.
That makes sense. Yeah, we know tobacco is a real problem. Obviously, you said the 1964 warning was the start of that conversation. What are they talking about, really? Are we talking about having a big black and white label on every single bottle of alcohol, whether it's wine or whiskey or beer or whatever? Is that what they're suggesting?
My understanding is they'll be adding to the current government warning.
Mm-hmm.
So there already is a warning at this stage.
Well, that shows you how effective it is. I've never noticed it before.
What is it now? Like pregnancy?
Right, exactly. Right now,
okay.
it comes with the risk of birth defects, and then also that consumption of alcoholic beverages impairs your ability to drive, etc. So, two things that everybody's we're all very well aware of.
Right.
I believe it's just being added to this statement, which has remained unchanged since 1988.
Okay, so they're saying specifically cancer. What kind of risk are we talking about? How does alcohol lead to cancer?
Depending on the cancer specifically, I mean, there are some different mechanisms. And the actual bulletin that the Surgeon General released is pretty easy to digest. I think we'll link it, but I encourage everybody to check it out. They at least have some good graphics and stuff in there of a lot of what we'll mention. So specifically referencing to the mechanisms that they lay out in this bulletin. The main one is that alcohol, when consumed, breaks down into acetaldehyde, which can damage DNA in multiple ways. And this is what ultimately leads to cancer, this downstream damaging of DNA.
Sure.
Also, it can induce oxidative stress, which again damages DNA and also the proteins and cells just by increasing overall inflammation. So those seem to be the two biggest. There's also the impetus of elevating certain hormones or changing, kind of the dynamic balance of hormones in the body, especially estrogen. There's a serious component linked to, breast cancer in women as well. And then there's a fourth mechanism that they propose, which is a little less understood compared to these first two or three. And that's the fact that alcohol can actually lead to greater absorption of carcinogens. And so that's whenever, if let's say you're smoking a cigarette, the carcinogens can actually dissolve in the alcohol. The alcohol alters the cells in the mouth, in the cells in your mouth, and then you're more easily able to digest those.
So it has a compounding effect almost if you're doing multiple of these behaviors, which makes sense. I mean, I know a lot of people, back when I was in my younger days in college and whatnot, people would say, well, I only smoke when I'm drinking. So that's oh, cool. So we're going to double dip on these things. That makes sense.
Yeah. And I guess the last thing I'll add, and then I'll let you take it back over. No. Those are the few of the mechanisms. Again, now what are the biggest, what are the cancers that we're actually talking about here? Yeah. And that's types of mouth cancer, esophageal cancer, breast and liver cancer, throat cancer, cancer of the voice box, and then also colon cancer.
Okay, liver cancer makes sense, and I guess the others, for the most part, because it's in contact with a lot of those things.
Yes,
interesting. For the sake of conversation, I'll play devil's advocate here. Do we really think that this label is going to change public perception? That I'm going to go buy a bottle of whiskey because I enjoy drinking a glass of whiskey at the end of a long week. Am I supposed to see this label and go, oh, never mind. I'm not going to do that now.
Yeah. So along those lines, I looked into the best comparison I could think of, which is the cigarette warning labels. And what we see with that is mixed. For example, one study looked at U.S. daily smokers who are not ready to quit. Okay. And it did not change their behavior. However, it did increase their awareness. Okay. So if you want to look at hard end results, there was not a change in the study time frame. But I think step one here, and what's still critical, is awareness. Because, for example, in the report itself, they do a rather large survey of adults, 18 and older, about their knowledge of what leads to increased cancer risk. And they asked about multiple different factors. 90% were aware of tobacco and radiation links to cancer. 45% were aware of the link to alcohol. So again,
huge gap.
Yeah. Endpoints are ultimately what we care about, but starting at awareness is critical.
That's fair. My question is, who are the 10% of adults that don't know that tobacco use leads to cancer?
Like, how you start doing those large surveys, I can't imagine what you really learn about people in general, but
nevertheless, okay, I guess that's fair that we want to help people establish that relationship in their head, that they're informed awareness. At the same time, I was in Spain a couple of years ago. It was delightful. In case anybody's wondering, highly recommend Barcelona. It's great. But in any store that was selling tobacco, they had warning labels on every single package. And it wasn't just a black and white clear statement. it included really graphic photos of different cancers that you can get from smoking. And at the same time, I saw far more smokers in Spain than I see in the average American city. So again, I'm just going, I don't know that this is going to make any difference. This just seems like an unnecessary government action that, to what benefit?
Yeah, I'll go into a little more regarding the studies. So there was also a study that looked at the size of the labels. So within a study, they did find that graphic, larger, more comprehensive are more effective in communicating the risks. They also looked at something that is adjacent. So in Canada, they have package warnings about that impotence. So there's multiple different, cardiovascular risk, cancer. They have impotence on there. So they're listing any of the possible issues. In Canada versus US, UK, or Australia, so Canada is the only country that has these, those smokers were 2.68 times more likely to know that it causes impotence. So in terms of impact, at least from an awareness standpoint, that's significant. That's showing that these are at least being seen and then translated to people when they were being asked a question about it.
Sure. Okay. That makes sense.
The other, and the last thing, this was a study in China that found, because on the first study I'd mentioned was only smokers that were already stratified based on not ready to quit, which is a significant factor here.
Right.
This study in China is much more broad-based. Okay. So they could evaluate what impact it had at different levels of what your smoking intake is, your tobacco burden, or your nicotine dependence. So they found that female smokers, along with light tobacco burden, they say, but light smokers and mild nicotine dependence, the warnings had more of an impact on them, both in terms of awareness and endpoints. So it does make sense when you start to stratify, what is going on with individuals and what decisions they're trying to make. Some people are hard and fast, and you're not going to do anything about them. That was kind of study one.
Right.
But people that are a little more on the fence, you can see that at least in this study anyway, there was an impact.
And then also I guess you could infer that this is planting the seed for people who are just learning about different health decisions or just general life decisions. So if you're an up and coming 13, 14, 15 high schooler, whatever it is, and this is on there, you like to believe that, hey, it's better that it's at least on there now. It can be talked about in the curriculum in schools a little more readily now. If it's this big change that it's taken 40 years to change,
right,
to edit. So that is very interesting. It speaks to how, again, how complicated the behavior change process is as somebody is working through either, consuming less alcohol or whatever it is, smoking and whatever the case. So it's like, does that mean you just not, change the labeling?
Right.
And along those lines, because that's a really good point. I think too, you never know when a label will have the effect, when it will have impact. You could be drinking or smoking for years and years, and whatever the case may be. So a family member gets cancer or something, and then the next time you see that bottle, maybe you're a little further on, you're having some other issues with these things, whatever it is, now that same label that made no impact on you for 10, 12 years now has impact. So I think having it on there in that sense at least opens the door for you to be able to receive the message that's on there.
That makes sense. And actually, that was one of the things that I was about to bring up, was that I wonder to what extent the smoking warning labels and the general awareness of tobacco and cancer may not have radically affected current smokers, but it clearly has impacted young people growing up. I mean, I know my generation, it was already, I'm not into that. I don't want to do that. I don't like the way that affects people. And then my kids had no interest in most of that stuff because it was just an assumed thing. I'm never going to do that because So I think that there probably is something to that.
It's generational, maybe,
right.
Because you even see now on those like vintage vintage retro TV commercials. I mean, they had like cigarette commercials and smoking commercials all the time. Like, cool down with a cool one, or, rip a dart. I don't know. They said rip a dart. I don't know
That's more your generation.
But I'd be curious to see, younger generation, because there's still commercials about it, which I heard one time. I actually probably should have looked to see if this was accurate, but I don't think alcohol commercials or beer commercials are allowed to actually show people drinking.
Correct.
The drink, whatever it is. They can show them having it or whatever.
Consume it.
But it's like this, it's a cultural thing. There's commercials about it. So I wonder, as this goes on generationally or with time, those commercials start to get pulled, or, I don't know.
Yeah. If it didn't work, they wouldn't spend hundreds of millions of dollars advertising. But the generational impact is probably more exciting to me. I guess that's the rub there is the individual decision-making process probably isn't going to be radically altered based on a label, but generationally over time, it could make a big difference.
Yeah. And I know even for me personally, there's a difference between a warning label on something with science behind it versus a restriction. So we're not discussing that you're only allowed to buy 2 beers at the bar. And, we're talking about a warning label. And to me, that's a huge distinction. This is not a restriction. This is just, hey, we're mandating something. It's government intervention, all those things, but it's a label on the bottle. It's not a restriction on what you can do.
Right. They feel just as strongly about the evidence that was presented back in 1988, that women should not drink alcohol during pregnancy because of the risk of birth defects. We now have something nearly as compelling to link fatal cancers and certain levels of consumption, that it's not telling you that you can or can't do anything, that it's, you're presented with the risks of all kind of things. This just makes complete sense based on what's already listed there.
Another thing you just mentioned, certain levels. So am I correct in assuming that this is not a one drink is the same risk as multiple drinks a night? So theoretically, if somebody is having very limited consumption, they're at a much lower risk, still elevated from none, but it's a lower risk than somebody who drinks 3, 4, 5 drinks a night.
Definitely. And with so many things like that, that's where it's hard to evaluate in a study. You can put people into groups and you can say what's light and moderate, but it is difficult because patterns vary. You've got more binger types. You've got just 1 glass of wine at night, but it's every night, and I think the impact of that has been evaluated to some extent, that the binging, if you have 7 on a night on the weekend versus 1 every night, those things are hard to stratify in a study like this, but there is evidence of that. So in terms of the raw numbers here, because I think that's still critical too, if you're making a decision or, we're trying to inform you to potentially have an impact. One of the components of this advisory report was a study that had 226,000 individuals, and they evaluated them over their lifespan to see what the impact was of drinking. And they found that 16% or 17 out of 100 of women who consumed less than 1 drink per week, versus incidence of cancer, versus 19% if they consumed 1 to 2. And up to 22% if they consumed 2 or more. So you can see even on a spectrum of those 3 groups.
That was per week?
Yes.
Okay, because that's not, 2...
I'm sorry, that's per day. That's per day, I'm sorry.
I was going to say, 2 drinks a week isn't even that much.
So 17, 19 to 22 if you don't consume, or it's less than 1 per week. So that's how they have, because then you could... So less than 1 a week is considered 0 in a lot of these studies. Goes from 17, 1 to 2 goes to 19, 2 plus goes to 22.
Wow. It makes me sad to say, but it seems like there really isn't, and we've talked about this before, there's not a benefit to drinking alcohol really that we can point to in any way health-wise, that there's no amount of alcohol that's good for you. And the less you consume, probably the better. Is that fair to say?
Yeah, it's certainly not like eating blueberries.
Right.
You know what I mean? But again, it's why it's this conversation. I think at the outset, we said that we're going to try to stick to, let's just talk about it in the context of cancer risk, different aspects of that versus, well, hey, let's bring in the cardiovascular risk. And what about the social element?
Sure,
and what about this? So not to,
Nope.
you ask the big important question, but it's just where do you draw the line for the sake of conversation? Because yes, you could make the argument that there's when they're trying to look at in those studies why maybe they saw a benefit observationally in those that were moderate consumers of alcohol or low consumers of alcohol. Was it because of the actual component of the alcohol that they were consuming? Most likely not. It's probably based on the patterns in their style of living otherwise. Maybe they're a little more moderate in other aspects. They do a little bit of exercise. They only eat a little bit of processed foods. They only smoked that one time when they were 16. It's like they have probably this set of characteristics in the same way that, if you're unfortunately, if you've been a lifelong drinker, maybe it was accompanied with smoking or certain dietary patterns, certain socioeconomic status, all of those things. It's just that when we talk about were these benefits of drinking overstated all this time, maybe. Yeah, I think maybe they were. Because again, I'm not sure whoever was saying that. Oh yeah, there's this one component that when you break down the alcohol, it just magnifies how well your cells do this and do that, and you can put on muscle, and you could do. It's just not. I'm not aware.
That's not a thing.
And I hate to go down this road too often, but in terms of alcohol and the industry of it, you've got a lot of power in a few companies, because you could say that about almost any study. Tobacco was similar, but it was so black and white. You start talking about big sugar or things. It's harder to quantify who's to benefit by a study like that. With alcohol, there's a handful of companies that stand to benefit significantly by a study like that coming out.
Sure.
And that doesn't mean I don't go all the way with it, but I'll leave it at that. There's a lot of open room there for some different interpretations.
Well, if nothing else, let this be a notification to all of our listeners that cancer risk is increased by alcohol consumption, and the best way to cut that risk is to stop drinking. Is that fair?
Tyler makes it black and white.
Well,
just like his shirts.
Mostly black.
I don't wear white shirts because I spill on myself way too much. No,
that's good stuff. This will be an interesting one to watch. See what the new label actually looks like. I couldn't quite find the new iteration of if they are going to make it more colorful or more hideous or what. Yeah, I don't know.
I don't know if they got into those details, but I think what's interesting too is going into the Trump administration. Yeah, because obviously with alcohol, there's multi-factors. You've got this whole social component, addiction component, cardiovascular. There's a lot of different avenues, but Trump doesn't drink.
I was just thinking that.
His older brother would always tell him not to drink, and his older brother died from alcoholism, from a heart attack in his 40s. RFK is a former heroin addict. His younger brother died of a...
Didn't know that.
He goes to AA meetings, and his younger brother died at 28 years old from a drug overdose.
Yeah.
So I say all that to say that I would believe that coming from the top, that there's going to be...
This will carry on.
This will carry some weight, I think. And given, again, I don't like taking away people's freedoms. So back to that point, that's not what this is. This is a very serious topic. It's already well regulated, as it should be. It's essentially a legal drug. And if they're going to put an extra warning label on there that has the potential to have an impact for somebody moving forward, absolutely. I personally am all for it.
Yeah.
Hey guys, we got a question in from Thomas. This one was emailed to us at questions@AskJoeDiMatteo. That's questions@AskJoeDiMatteo.com, AskJoeDiMatteo.com. You can email us questions there as well. Thomas said, hey guys, I'm 69 years old and my cholesterol is high. It has always been high. My HDL is 50, but my LDL is 256. Oh my gosh. I take fish oil, niacin, and turmeric matrix essentials. I've been avoiding statins, but I am thinking about giving in to Lipitor. What are your recommendations? I've been a fan of your ministry for probably 20 years. Thank you, Thomas. Well, thank you, Thomas. Those are some high numbers, or do I not know my cholesterol very well?
Definitely. So assuming that he likely means that the 256 number is his total cholesterol. We'll still highlight how, either of these pathways would go if that number is reflective of his total cholesterol or just his LDL cholesterol.
Okay.
So let's say that what he stated is his actual reading. Then we would probably have the inkling that he's dealing with some sort of familial hypercholesterolemia, which we won't go into a ton of detail over. When that's the case, usually, you'll be tested earlier in life. You'll have there's often a family history of this genetic component, or you see early instances of cardiovascular disease in family members, first degree family members, early heart attacks, those sort of things. So for a lot of people, they might get this sort of inkling earlier in life. Now, it's not to say that it's not to say this is impossible, but again, it's often, maybe established, and then you're often treated a little bit earlier and more aggressive because, as we'll discuss, and as we've discussed in the past, the earlier that you can intervene on elevated blood cholesterol levels, the better.
Yeah. So that's the Lp(a) number, correct?
So it actually is not.
Oh.
So it's kind of a separate, up to this point, a non-modifiable, low density lipoprotein, basically. So
Okay.
Lp(a) we can reserve for maybe a
separate
later
conversation.
Yes.
Okay.
So when we're talking about instances of whether it's heterozygous or homozygous familial hypercholesterolemia, it's often just in reference to really high total cholesterol or really high LDL cholesterol.
So some people just have, genetically speaking, higher cholesterol.
Yes, exactly. So there's just some marker that they carry that portends them to much greater risk, sometimes 2 and 3 times the normal limit of cholesterol measurement.
And you're saying that would show up earlier just because either family members, his parents would have also had this issue, or maybe he would have had some indication early on that, holy cow, this cholesterol is way too high for what it should be theoretically based on lifestyle, diet, exercise, all those things, and your age. Okay.
Exactly.
All right. So if it is 256, his LDL is 256. That's a very high number.
Mm-hmm.
What's the recommendation there? I assume that fish oil and turmeric matrix essentials are not going to get it done.
They will not, unfortunately. So the other kind of aspect of this is when we're talking about how we handle elevated cholesterol, or you handle managing cardiovascular risk. The first instance is, in his case, has he ever had a cardiovascular event? Is there evidence of existing cardiovascular disease, whether that's different imaging that can be done, or again, has there ever been a stroke, a heart attack, etc.? So in his case, he didn't mention it. We'll assume that his first, encounter with this range of risk factors is just that he has some elevated blood cholesterol. So we'll assume in this case, he would be treated under the primary prevention lens.
Right.
And so in that case, right off the bat, because the reading is considered extremely high, he would be a candidate for higher intensity statin therapy.
Okay.
And so that's things like higher dose atorvastatin or Lipitor. That's a med like Crestor or rosuvastatin at the higher dosing. And that's because those medications have the most evidence and they are most effective when somebody has, more than average elevations.
Okay. All right. And so it's a fairly cut and dried answer. If his LDL is 256, stop hesitating, go talk to your doctor and get this under control.
Right. And I'm glad you mentioned that, because we're always just talking more or less in theory. If we have this patient, if this patient was being seen, how might the conversation go?
Right.
So yes, at the outset of even within these guidelines, the first step is, because there's often not a black or white medication choice, so there's not a black and white time to start a medication choice. As we know, some of the cholesterol lowering medication discussions are a bit controversial.
Yeah.
The first thing is to come to sort of a shared discussion with your provider. And that's point number one in the guidelines from 2018. And so the point remains the same even in this conversation.
Go talk to your doctor.
Exactly.
Okay.
So before we kind of dovetail away from that, the number for primary cholesterol that you're looking for. So in patients with severe primary hypercholesterolemia, LDL-C greater than 190, greater than or equal to 190 milligrams per deciliter.
Okay.
Even without underlying cardiovascular disease, it's recommended to begin a higher intensity statin. And the goal is to get this below 100. And so the only way to do that, unfortunately, it's not typically fish oils. It's not typically things that you can buy over the counter. It's the tried and true cholesterol lowering meds, like we mentioned, the statins.
Yep.
There's even, there are even some different recommendations, some schools of thought with adding other medications to statins that are available now. Things like Zetia, that's been around for a while. It's cheap. It's well tolerated. It lowers cholesterol by a little bit of a different mechanism. And now there's even been the emergence of the PCSK9 inhibitors, which have come down in price a little bit. Things like Praluent. And so in individuals who have the familial aspect of this, or they just are being treated in a primary sense with pretty high numbers, those PCSK9 inhibitors are often added. And I think they're used a little more frequently now than even, when Joey and I were in school, when they were cost prohibitive and there weren't as many indications. Now you see a chunk of people who have maxed out their statin dose and they end up on one of these other meds.
Okay. And one of the other things, I know he said he was hesitant to do this. He's been resisting it. My understanding is that it's not like it used to be. It used to be that there was one statin and one size fits all kind of sledgehammer approach to things, but you're just mentioning half a dozen things right there. There are lots of options. Mm-hmm. And correct me if I'm wrong, my understanding is that if you try something and it's not working or there's too many side effects, there are multiple other options that people can try to try and get the same effect that aren't going to have the same downsides. Is that right?
That's exactly right.
Brilliant.
I like that point because there essentially have been generations of statins that have come out. So the original being lovastatin, which many might be actually familiar with lovastatin because that's essentially what is the active component in red yeast rice products. And so that's kind of the one that was initially studied. There were some others, things like pravastatin, simvastatin have been around for a long time. They're still being used. And again, now meds like rosuvastatin, which you might consider even an enhanced or a better side effect profile.
Cool.
And then for a lot of people, the most common issue are the muscle aches, the myalgias, things that become pretty, negative in terms of somebody maintaining adherence to a given treatment. So they'll stop taking them on their own as soon as they have muscle pain, muscle aches. And it may have been because they started on a higher dose. They fell into a certain category. They started on a higher dose. Now with the emergence of some of these other meds, there are instances where you can get away with a lower or a medium dose, and then you can add one of these other agents at a lower or a medium dose, as opposed to always just maxing it out just because that's the way things have been.
Yeah.
So and same goes for hypertension meds at this point. There have been changes in those guidelines, even as an aside, that advocate for a similar sentiment where you're not always just maxing out the dose of amlodipine or metoprolol. You're starting at a low medium dose, and before maxing that out, you might add this other thing, and then you might add this other thing, which for a long time that was crazy.
Right.
Why would I want to be on 3 meds or 2 meds when I could just be on 1? And I get that, but then when you start maxing doses out, that's when you see the highest chance for toxicity and side effect, et cetera.
That makes sense. Okay, cool. You had said we're going to look at this as if perhaps that's his total cholesterol and not his LDL. Mm-hmm. What's the difference there?
So if that was his total number, there's still a chance that his LDL cholesterol calculated would be greater than 90. And so we would have to know his triglycerides as well, because a lot of times what you see on your blood panel, they're calculations of this LDL reading. So if we had a triglyceride, we could sort of deduce what's there.
Do our own calculations.
Yeah, but let's just say that he is, if he's below 190 on the LDL cholesterol spectrum, then it leaves a little more room for interpretation. And so historically, when somebody may or may not be a candidate for these medications, they essentially pull all this different information about the person and then spit out a risk percentage of their chance essentially to have one of these major cardiovascular events or, ASCVD. So it's not always like you walk into the doctor's office, you get a cholesterol reading, and that's the determining factor of what dose you're on. That's a part of it, but there are all these other, factors that are important.
Okay. So what are some of these other factors? I assume age is probably part of it.
Definitely. Age, gender, race, total cholesterol, HDL, as we mentioned, systolic blood pressure, presence of diabetes.
Okay.
Is the person receiving treatment for high blood pressure already? And also whether or not they are currently a smoker. So all of those things go into a calculator. And again, that's what spits out somebody's risk for ASCVD or atherosclerotic cardiovascular disease.
Okay.
And then there are also kind of risk enhancing factors outside of that as well, which further lead to more
aggressive treatment.
Exactly.
Okay.
Exactly. And so those are things like metabolic syndrome and chronic kidney disease. And then whether or not maybe you've had a coronary artery calcium score calculated or you had the imaging associated with that done. And so all of those things are just to help paint a better picture to whether or not somebody needs more or less aggressive treatment. And so because we don't have a whole lot of that information for him, you can kind of only go so far. But this is just to, I think, shed light on how nuanced even something like this is when everybody just thinks, well, you just walked into the doctor's office and they write you a prescription for a statin. They do that for everybody. It's like, well, it might seem that way, but there are a ton of different things that are looked at in this respect.
That makes sense. Okay. So now obviously you're not a medical doctor and we've just thrown a bunch of information out there. For Thomas's sake, what's the take home here? What's the punchline that we want him to hear?
Per usual, went off the rails a little bit to try to add color. Yeah. Yeah. But again, it's just important to reiterate that you think you just walk into the doctor's office and then they spit out a statin on the other end. And it just feels that way because cardiovascular disease is the number one, heart disease is the number one cause of death in the United States. So is it any wonder that you see, that it just feels such a prominent, connection to it. So I would say the first take home is yes, have this conversation with your doctor as soon as possible to, again, maybe not even just harp on this cholesterol number, but to understand maybe some more of those levels, some more of those readings, some of the things that might be considered risk enhancers for you, things that you may not have thought may play a role in your risk for, this super prominent disease in the United States. So that's number one, is just have the conversation. Number two would just be, hey, in a perfect world, the sooner, the better that you begin to take control or you begin to try and lower these levels and monitor these levels, the better. That's what we've talked about in prior, cholesterol podcasts and little excerpts. Also, we know that it's better to get these numbers lower. Yep. The lower, the better.
Yep.
And if you're already high, it means more in that case to get them as low as possible than even somebody who's already moderate or low.
For most people,
yes,
it's virtually impossible to get them too low.
Yes. And that's even with the Peter Attia stuff, that's where I think landed, and that's where he's landed, is it's sort of just like, we know how serious this is. We know we have control over these numbers with some of the meds that we have and via lifestyle, that would it be the worst thing to be more aggressive? The next thing would just be, again, to reiterate, the higher the LDL cholesterol is, the more important it is to aggressively lower it. And then, again, we'll also see that finally, if he finds out that, oh yeah, I have a coronary artery calcium reading done, or you know what, I had a mini stroke 10 years ago, and you are somebody who you can then say has established atherosclerotic cardiovascular disease, it's even all the while more important to begin to pursue some different treatments and other instances where it then becomes secondary prevention of one of those events.
Love it. Love it. Thomas, I hope that helps. Go get this taken care of, my friend. We need you around for another 20 years listening to the show. That's it for us this week. Thank you so much, as ever, to all the folks that make this show possible. Thank you to the three of you wonderful humans. If you guys have any questions, we would love to hear them. Questions at askjoedimatteo.com. That's askjoedimatteo.com. That's also the website where you can find more about this show, find any of the products we mentioned, or any of the show notes, anything that we talked about. It's all available there on the website. Go check it out. You can also email us, sign up for the newsletter, all sorts of great stuff. If you like this episode, give us a thumbs up. Share it with 5 friends. That's the assignment. 5 is the magic number. And other than that, can't wait to see you guys again soon. Have a great week, everybody.